Here we are back for another episode. I'm so excited that it's tax season. Oh, wait, it's April 1st. No, I'm not. This is horrible. And so I'm just going to kick it off, Renee. We're not going to do an introduction. I'm just going to start complaining because this is the worst time of the season for a farmer, for a small business owner. I am in the thrust of tax season and it is horrible, Renee. The worst tax season ever. And so I'm not even going to start talking about it because I'll just keep going and I won't be able to stop.
Oh, good morning, everybody listening out there. Today we are talking about the emergency departments and the growing role of pediatric behavioral health access in those emergency departments. But Jason's on a roll. He's having a rough day. We thought we'd kick it off a little different today, talking about tax season. He's a very unhappy camper. One of the pieces he forgets to tell his audience is that he's newer to consulting, and that consulting can bite you in the backside when it comes to taxes. And unfortunately, he's learning that the hard way this year
It,
and mad about subsidies and all that. So,
well, it's
goodness, Jason,
math.
anything
It's
else you want to say
math.
about
It's
taxes before we
math.
get on?
When you don't keep track of I knew things were coming in throughout the year, but simple math, Renee. I guess I need to run a few more reports as we go through the year just to double check that maybe more didn't come in than I thought did.
Well, it's a good thing our
Because
state's bringing in what is that extra special help for math and for tutoring in schools. And so maybe we can
right,
get you caught back up. Be
right.
like, can I do a remedial course about that
I
about a few
know.
years later?
I know.
Can I just
Math is
catch you?
tough. Math is tough. I got to tell
Math is
you.
hard. So today we're going to start out chatting about what's an access center. And when it comes to kids, we all know that the emergency department is really where parents usually end up going to start to access care for their kiddo. And a lot of times, you may even before you get to the emergency department, maybe you've gone to your primary care, you've gone, because you're something's up, but you don't know what. But you get to primary care, they've done some testing, maybe they've looked over your kid, and you're like, these are just things are just not right. And then you realize there's more to it, but you just don't know where to go next. And so then if there's a crisis where it could be maybe there's an explosive behavior at home or an illegal behavior or something that could be perceived as illegal or just really inappropriate, parents don't know what to do, so they go to the emergency room. And so the emergency room now has become kind of this de facto place to get access into care. The secondary one we're not talking about today, but it is a really big problem, is jail, and especially in juvenile detention. And kids in the same situation end up doing things that are maybe not fully I mean, they're just inappropriate, but as they may age, they may get arrested for those things. And so you end up with these two places that neither one are correct. So we're going to talk today about access centers and how it would be better. So Jason, kick us off. What is an access center and how could this help families?
Yeah, and I think it's been fascinating for us to watch, here in the state of Iowa, because there was a big movement 4 or 5 years ago to develop an access center model, kind of that no wrong door approach where everyone would have access within a certain, 60-mile radius to walk into some place to be able to receive an evaluation, to be able to help to navigate the system and access services, right? Help scheduling appointments to help to get to the right place to get the right medications and get those medications filled. And what happened was that never really happened, right? It occurred at different levels. It wasn't really designed for kids. It's really designed for adults. And so the state never really figured it out. And so, we've seen it happen regionally in other states, but no one really has a good large scale system figured out of how do we manage behavioral health conditions. And so what happens is, especially in rural areas, our critical access hospitals get this influx of patients that they have no idea what to do with because they aren't trained and oftentimes they aren't connected. And really that's what we're going to be talking about over the next couple of episodes is this model of an access center. It's kind of like urgent care, right? Like we all know that, most clinics have moved to an urgent care model for, late evenings to divert people from emergency rooms, right? So if I have an ankle twist or something that's not emergent, oftentimes I would just go to urgent care if I couldn't get into my own primary care physician and have my ailment taken care of. We've been much slower on the healthcare side to do something like that because we really don't understand what we need to do to support people when they're experiencing an emotional crisis.
Yeah, and we are going to talk through some just stories, and I won't name any names or identify specific people, but I mean this particular conversation is very common with families that are struggling. And I know just from my own background, years ago, I was a as a foster parent, and I was supposed to be guaranteed support, but I took tough level kids on purpose,
Mhm.
kids coming out of institutions. The idea at the time was to try to stabilize them in a family style home so that they could move into a more of a long-term home setting. So I knew I was taking tough kids, and I was promised that type of support to wrap around me to be able to keep them in my home. And I know that I ended up with two kids, one in two different hospitals at the exact same time. And so I have lived this myself as a foster family, and know that this is a story, unfortunately, over and over again. And I wasn't in rural hospitals, but I'm sorry to tell you, but bigger hospitals didn't really know what to do with us either. And so
Mhm.
we had a little bit more options, and maybe they could stay for a few days before they got pointed in the right direction, but it really wasn't the right place for either one of my kiddos. And they were like preteen teenagers at the time. So, I've lived all of this, and it's really hard. So when we're talking about an access center, if we had the pie in the sky, what's it supposed to do? What's it supposed to do? I mean, the concept of a place where you go, you get immediate access. What are you supposed to get when you're there? What's the concept that we just keep falling short of?
Well, I think the concept is we just need to be more quick and readily available to diagnose and screen and connect people to the right level of care across the continuum of care, right? And so, I mean, our
Right,
first issue is there has to be a continuum of care to connect people to, right? When
right.
we don't have any of those other levels of care in the community, then it makes it much harder to get someone to the right level of care at the right time. We're just really bad at connecting people and plugging them in to the services they need at the time they need them. Our healthcare system in America is just really poor at doing that. We're much better when it comes to cancer, right? You walk in, you take a test, and then there's a diagnosis, and then there's a treatment, and that can all happen within a week or less, depending on somehow they always have you can get an appointment to go through that process. When it comes to behavioral health, it's clunky, it's antiquated, it's outdated. We aren't using what we have efficiently. And so we end up with people waiting for 30 days while they're suffering with horrible levels of depression, where they can't go to work, where all these other things are happening, aren't able to access the correct medications, don't receive the correct diagnosis, and that can go on for 6 to 12 months unnecessarily. And so this is my soapbox, Renee. Maybe you don't know that. There's really no reason for that. And so if we really wanted to create an access care, behavioral health urgent care, we would have the appropriate professionals available to screen, diagnose, and then connect that person through more of a care management. We've talked about community health workers, right? They're
Mhm.
navigators. When we see the community health worker movement happening in other states, what a great model, a very low cost navigator option. Why aren't we doing more of that? It doesn't make any sense that we wouldn't be doing more of that, considering what behavioral health conditions cost the economy and businesses every year. And so when we think about how easily we could fix this system, and why we don't, we all know it comes down to one thing, and stigma plays a large role in that. Boy, I hit all of the talking points in one 3 minute just
You
complete
did. You
outburst.
did. Yeah, and so I want to just share a story. A friend of mine, and this is this current situation, but I've heard it from others. You just talked about stigma, and that goes back to labels, which goes back to diagnoses. And I had a friend who needed a particular level of care for their child that they needed the particular diagnosis in order to get. Well, the doctor didn't want to label the child because they didn't want to give them a label, and maybe that's for stigma purposes, maybe it's not, but she needed the label to have the diagnosis to get the access to the level of care. And then that level of care said, well, we can't take you until you get that diagnosis or till you get that label. And so you go back and forth with like doctors who don't want to stigmatize or label children, Okay, get that. But then you have high needs kids who really need access, and the only way to do it, you have to have a diagnosis. And so then the family is just stuck. There's no options for them because the two sides are warring on who's going to
Right.
do what. And then the treatment place is like, oh, well, we can't let you in without it. And they're saying, oh, well, we can't give you the evaluation. And so you just go around and round and round. And even in that case, there is a proper level of care. There is a place for a child
Yep.
to be, and they still can't access it. So when we're talking access, the bumps to access are many. And that wasn't insurance. It wasn't, there's lots of things, right, that can go wrong in
Hmm.
getting access. It wasn't those things. It just seriously was that conversation about labeling and stigma and diagnoses. And so it's really, really frustrating for a family when you have a child who needs help. And the same happens. It's a little different, but it's still pretty clunky if you get like an autism diagnosis or
Yep.
on the spectrum, or you're not neurodivergent in some way, you're not developing at the
Hmm.
normal paces. It's pretty clunky for families. I have another friend that has seizure disorders in their child, and that is medical, but it also then crosses over into maybe behavioral analyst type treatment to help because he's going to end up being on the spectrum.
Hmm.
And so the medical part, you might get the help, but then you don't get the services because it crosses between. And so with kids, they're pretty complicated little folks. They're not
Hmm.
just small humans. I mean, it's complicated. They're developing. So as they're developing, you don't know for sure if it's behavioral health or if it's medical, and those two have to work together. And it just doesn't work the way we need it to. And so we're talking about this place where you could have all of this care in one location, and it feels like from where I'm standing, it feels just like a pipe dream because it feels like it's just so far away. We're just nowhere close.
And
Jason, we just had a lawsuit in our state about exactly this, and there's legislation moving that's supposedly going to put some of this together. Do you have any thoughts on that or heard anything about it, or do you think that's going to help us in any way, shape, or form?
well, yeah, I mean, I think there's been multiple lawsuits in our state, and I mean, and one of those was just settled around kids sitting in EDs and not being able to access the appropriate level of care at the right time. And I think it's going to take years to try to figure out that system because we don't have a kid system in this state, and I think that that's really complicated because we're so inequipped and we don't have the appropriate professionals. Board certified pediatric psychiatrists are few and far between in our state. And so, really thinking about the specialty that's needed in our state is a challenge. And I don't want to make it seem so doom and gloom. I mean, there are in some of our larger cities, there are some behavioral health access centers in hospitals. I think of Broadlawns, does do that. And they have walk-in opportunities. The issue is this doesn't happen across the state, and this is a real challenge in rural areas. And so we really need to think about how do we think about this differently because our emergency departments are failing us today. And so if we could jump to some data, Renee, I would love to just kind of talk about like we're just not making this up, right?
Mm-mm.
Like we know that 31% of kids get an outpatient visit within 7 days of being in an ED. 60% within 30 days, and the other ones probably never get a visit, right?
Mhm.
26% of kids will return to that same ED within 6 months, right? That's 1 out of 4 will come right back in the same door with the same presenting issue. And so we're not doing a good job of identifying and referring and helping to remediate the issues of why that person presented in the ED in the first place.
Yeah, I don't know if you're going to remember this, but you and I had a conversation a while back about crisis. And like, remember when we first started talking with the regions and we talked about like what a crisis cycle looks like and how
Mhm.
you hit the crisis and then, you need to have follow-up care within that 30, 60, 90-day
Right,
window, or you just start a crisis over again. So what you
right.
just said about the return rate within 6 months, you're saying over a quarter of our kids within 6 months are just having a new crisis, and it could be even shorter time frame than that because once if you don't address it, so your soapbox may be all about taxes today, but my soapbox is always about handing that outpatient
Right.
card in the ED, and we talk about that on every time I get an opportunity on this podcast. That is the dumbest crisis plan ever because it's
Mhm.
not at all what that system is designed for. An outpatient is not a crisis service. And so that's
Mhm.
just silly. But again, this is this data you're talking about here. This was, they're talking about props given for people getting an outpatient appointment within 7 days, 30 days,
Mhm.
whatever. Great, but that doesn't really help. And to your point about cancer, cardiac issues, diabetic emergencies, an outpatient card 6 months from now, all of those people would be dead. And so it's like, why in the world in this system is that okay? That is crazy. And so we continue to fight that. But we also have some other data that we wanted to talk about. What else is going on in data world that you can share and then talk about the fact that this really is a problem? It's not just our opinion, it's a problem.
Well, part of it is, we're seeing more and more kids present at emergency
Hmm.
rooms, right? We've seen
Hmm.
that really since the early 2000s, the mid 2000s. We really saw that start to increase. And now we see more kids showing up at the ED and they're sitting in the emergency room for 2 times longer than any
Mm.
other of their physical health issues. So we look at counterparts who come to the ED with a physical health issue. If you have a mental health condition, you're going to be sitting for 2 times longer. And I think that that's a concern, right? 1 in 5 mental health related visits last longer than 24 hours. And so, we're
Wow.
going to talk in some episodes coming up about boarding, about what that really means of holding kids for 48, 72, 5 days, 7 days in an emergency room. How that's not okay. And so, where has our system failed us that's all we can do? And we mentioned it at the kind of the top of the episode, but I think we kind of have to circle back to a lot of the referrals to the EDs are inappropriate. The kids
Right.
shouldn't even be in the ED in the first
No.
place because the community system of care failed them. That's how they ended up in the emergency room because
Right.
either there doesn't exist a different avenue or path, or no one knows what that other avenue or path is.
Yeah.
And, I see this a lot. We talk with schools or we talk with communities, and sometimes people just throw their hands up and go, well, just take them to the ED. We don't know what to do. And so that really places a lot of pressure on your local emergency department. They're not equipped either, but they're taking folks who they're not designed for, and they're not having an acute mental health issue. And so, that really goes back to the community partnerships and the community system of care, and how can we do a better job of guiding people to the right place at the right time?
Yeah, and I think about this from the kids' perspective, but also from the parents' perspective. I have a family friend that, adopted difficult children and ended up themselves in the psychiatric hospital because they couldn't take the
Yep.
pressure of caring for the child. And then they end up losing rights to their own kids because they end up in the hospital.
Yep.
And so it's messed up from all sorts of directions. It's wrong. So it's sometimes if you put so much pressure on the family because there's so little resources to care for high needs kids that the family member ends up in the hospital, that's wrong. And then on the flip side, or they don't know what else to do, so they bring him to the hospital, the kid, and then say, just keep him. And that's not, we were talking to, was it Nebraska when we had that conversation with Annette about the fact that they had it where people could drop off kids at the ED and it wasn't just babies. They had done the
Yeah.
legislation wrong, and
Right.
people were just dropping off children in general of
Adolescence.
all ages.
Adolescence. Right. Right.
Yeah. And so instead of a safe haven act like we have in Iowa for
Right.
newborn babies, they didn't put an age limit on it when it first came out, and people were just dropping off children because they
Right.
had no idea what to do with them. And if you look into the history of asylums and institutions across our country,
Mhm.
that's what happened to lots of children. They would just be dropped off at an orphanage or whatever they
Mhm.
would call it at the time, and the child would just disappear. Early in my clinical work, I worked in Texas at a children's home, and there are records that became open over time that were closed originally, where we
Right.
never ever found the paperwork because it
Mhm.
literally was almost like a child was left by on the park bench at this place. This children's home would pick up a child
Mhm.
and adopt them out, and then no paperwork would be done. There would be no way at all to figure out like their background, and that's
Mhm.
in my lifetime. So it's
Mhm.
not like this was a long time ago. We now just have people with eyes on these kids. And so now they're stuck in EDs where in the past they would just be dropped off, left, who knows what else happened
Well,
to kids. And so it's a long problem.
and we've done trainings with hospitals where we talk about the patient you're missing are the parents and caregivers that brought in
Absolutely.
the person who's in crisis.
Absolutely.
And our nurses and ER doctors don't get training on how to support the caregivers. That's the missing patient in all of this. And we really need to be identifying those folks as the secondary patient who is accompanying the young person. We're talking about pediatrics. This can be the same in geriatrics as well, right? Because we
Yep.
talk about caregiver burnout. We do a lot of
Yep.
training sessions around this where we talk about let's remember the impact on the caregiver
Yep.
and what's that's doing to all of this. And our system doesn't even recognize that. Right.
No.
And so there's number one. If that caregiver is responsible for follow-up and continued care of that person who's experiencing a mental health crisis, and they don't have stuff together themselves, then the prognosis for that person getting better and getting the care they need goes down exponentially. And until
Right.
our system recognizes that, this isn't going to work.
No. And you and I talk about working in provider, teaching provider with NAMI. And one of
Yep.
the things about that I really appreciate is that part about caregiver burnout and
Hmm.
about the fact that, doctors often get really frustrated with the family because why won't the family take them back? Why won't they do
Right.
more? But by the time a family has brought a child or, to your point, an independent adult to a
Hmm.
facility and they can't do anything anymore, that then person who's trying to give care needs help. And if there's no support for them, then they can end up in a psychiatric break or in the hospital or medical issues. You hear all the time about adult caregivers taking care of their parents who end up with their own personal health issues because they just can't take care of themselves while caring for others. And this is an ongoing conversation. So, yes, we're talking pediatrics, but you're right. Any child, and it's not just about children, right? It's people with disabilities,
Yep.
the aging parent. There's a lot in
Yep.
our community where the aging parents are taking care of their loved one who may have Down syndrome or who may have another intellectual disability. And when those parents die, then there's a fall off. And then what are
Yep.
you going to do with those adults? And so there's just a lot of gaps. And then they end up in the emergency room. And so then
Right.
our small hospitals just don't really know what to do. And so it's a process where there's just a big issue with just all kinds of different challenging situations. And so it can be some physical limitations that go with it, right? It's not just always mental health, but it could be a lot of other issues. And so we're just not equipped. So the concept behind the Access Center really is to have that one-stop shop, that kind of that ER, if you will, for mental health, where people could come and get that referral, the screening, and then get put in the right direction. It's really the same as our 988 system, right? It's
Yep.
supposed to be pick up the phone, you know, get a response to come to you and they have a place
Yep.
to go. And we're falling short there too. So it's like the
Yep.
systems should, by way they're designed in our minds, should go together. That access center and that, because you could send them to that access center to then continue down the path. But man, we're just so short across all of this. And so it's really frustrating. So what else would you like to talk about this particular topic?
Well, I think really it's we're teeing this up for the next steps of what are the solutions, right? And I
Yep.
think it's we're not saying that every small hospital has to do everything across the entire continuum. I think what we really need to do is shift to who's responsible for convening all of these folks across the continuum of care and across the local community. And I think I hope you tune into the next episode because we're going to dive in to how can your local critical access hospital or community hospital be that convener and develop this concept of access center across a multitude of different organizations
Right.
and really have that access and availability in your local community.
Yeah, I agree. I'm looking forward to that conversation. But before we go, we're going to have a recovering politician self-care policy of the week. Did you know, Jason, that people have paid time off or PTO in their companies and they don't use it?
I do
Did you
know
know
that.
that?
I hear it every time we speak. I ask people to raise their hands if they're carrying PTO over year to year, and every time half the room does this, and I just look at them.
Yeah. Two-thirds of Americans, Jason, leave paid time off on the table. So they're leaving millions of dollars in the company's pockets where they're getting paid to not be at work. And so today's tip is use your paid time off. Now, Jason and I being consultants, we don't always get paid time off. We just take time off. And so it's a different issue if you're self-employed, work from home, work on the farm, and it's different. And so that's different. But these are folks that actually take jobs, and one of the benefits is getting paid to not go to work. And people are not using it. And so it is unfathomable to me. And as Jason and I just came off our time off of us for rejuvenation, refreshment, we just want to remind you, if you're working in a job and you have paid time off, use it. That's what it's for. Don't wait until it's a crisis, until you're so crispy at work that you're burnt out. If you get to burnout, you missed all the chronic stress that came before it and all the off ramps where you could have done something about it. So just think about, how are you going to use it? Whether you take just a day here or there. We talked about this a few episodes back, where I have some people in my office will want to just take a few hours here or there, half a day, so many days, maybe a day a week, they want extra half day. Some other people bank it all up and then take 2-week travels somewhere. It doesn't make any difference. Other people use it and stay home and just be with their family and their kids and don't come to work. Doesn't matter. The issue is you get it as a benefit. Please use it. And that's my recovering policy of the week. So before we go, just want to kind of sum up what we're talking about. First off, Jason's mad about tax season. So there's that. And tis the season for taxes. But we also talked today just about not the emergency room and how it's become sort of that go-to place for pediatrics, for people, for children. They just don't know what to do with them. And so they end up in the emergency department. So we talked about lots of the challenges this time, just really telling you about the data, about all the things that we know are just not right. We're talking about an access center, what it should be, and just really the reality of what it isn't. But join us next time, because we're going to talk more about what it can be and how you can use convening and pulling people together to make a big difference. But before we go, I just want to remind everybody to please follow us on LinkedIn, Facebook, or YouTube. And if you give us a positive review, we're going to send you a prize. See you next time, everybody.